have to continue to entertain any questions.
I think I'm overwhelmed.
They're going to ask you to explain UPL.
I know.
Courtney. Again, please identify yourself, even if I'm new.
Deborah, you had talked about cost being essential, controlling cost being essential as we're implementing the reforms, and you seem to focus a lot on reimbursement. Costs are really concentrated in the long-term care side of things, in the disabled population. I was wondering if you had some thoughts on what are some of the best ways that we can control costs in that arena.
I agree. We've got to focus on the populations that are the most medically complicated and the most expensive. So those are individuals with multiple comorbidities. In the case of Medicaid, it's almost always has some behavioral health problem associated with it, and it's the dual eligibles. And what do we know about those two populations today? They are unmanaged. They are unmanaged. And we have exempted or excluded individuals with serious mental illness from health plans, and we have excluded some of their mental health and substance use benefits from the managed care benefit package. I think we could take another look at that. There may be other ways to manage their care, but in New York, we have a very successful Medicaid managed care program. We have a vehicle, and I think with appropriate oversight by the Department of Health, we can do a better job of caring for and paying for these individuals. Same goes with the dual eligibles. We have several vehicles to deliver integrated care dual eligibles that combines Medicaid and Medicare revenue streams. They have not been particularly successful in terms of numbers, and I think we have to take a very hard look on how we can better manage the care of duals. Now, federal law bars us from mandating the dual eligibles join plans. However, we can put certain benefits into managed care exclusively. Maybe our personal care benefit should be put into managed care and no longer deliver fee-for-service for individuals that need long-term personal care. There are other long-term care benefits as well, but we need to really tackle these populations and the long-term care services to see how we're going to better manage the care of the people and the utilization of the benefits. And I would just say that for 2 years running, I know the health department has proposed both putting personal care into the managed care benefit package. It has proposed redoing how we pay for home health care to better incentivize efficient and effective care. And all stakeholders will never agree, but we really need to tackle these issues because that's what we need to do. I'm getting on my high horse again, but that's what we need to do, not across the board rate cuts.
Yes.
Hi, Kate Breslin from the Schuyler Center for Analysis and Advocacy. Thank you. That's great. One of the things that I've been thinking about a lot is the kind of the workforce side of things with regard to healthcare reform. So I'm curious about kind of the whole thing and who's looking at that from the big picture perspective in New York State. What does our workforce need to look like, and not just doctors, but who else do we need, and how are we going to make sure that happens?
Well, I haven't done much work in workforce. I'll see if Dick has an answer. The one area where I think New York has to take a hard look is for our mid-level practitioners and make certain that our laws allow them to practice to the top of their license. There are many models where nurse practitioners and midwives and PAs can deliver primary preventive care as well as or better than physicians. And we need to, and every state needs to do this, to make sure that our laws allow them to practice to the top of their license. I don't know where we are on that, but it's clear to me that that's one issue. Another issue that we started when I was in Medicaid, and other states are starting to realize, is that we can increase payment rates to doctors, and you know under the ACA, Medicaid rates for primary care physicians will increase for 2 years. But we also need to make sure that Medicaid is a better partner with our physicians and our clinicians all together. And so we need to make sure that providers are able to enroll in Medicaid. Now that's Medicaid's answer. There's a much broader answer than Medicaid, but that's an area where we have direct control. Did you want to say anything?
Well, a couple things about that. Back when Jim Fawcett and Courtney and Tom and others of us here were working on the commitment plan, we published 2 books with the Brookings Institution on reforming healthcare. And there was a chapter by Michael Spare. One of the best parts, I've been going back and reading a lot of stuff. One of the best parts of there were 2 Brookings books. That was the second one. Was his treatment of, Kate, what you said, is the challenge of workforce, and I mentioned that. And, I mean, Deborah doesn't know the subject well enough. That's a big problem.
I admit it.
But what you have to remember is there got to be 50 Deborahs, and there are 50 states, and they're doing different things on workforce. And I underlined one sentence of your excellent presentation. I mean, it really helped me to think about New York, yes, but the theme, one of the themes of my talk, which is 50 states are listening to people hopefully as knowledgeable as you are, and they're coming from all sides. I mean, I'm not saying you're coming from a side, but there are lots of sides here. You made a statement. You said we have to make choices among providers, and that is hard to do, you said, rather than across the board changes, you said. Well, that is what a student of mine when I was in Princeton is now the commissioner in California, and we are working in all 5 of the largest states. We have people who know a lot. Many people know as much as Deborah. But in some states, they have tackled these kinds of challenges in different ways. And this is, her name is Belshit, Kim Belshit, is Commissioner of California. And I don't think I'm telling anything I shouldn't. And what she said is that we can look at the exchanges the way we've talked about it today, mainly in Deborah's presentation, to dig down and to see all the things, the Magi, the gift of the Magi. I mean, how ever are they going to do that? That's IRS data that's mostly 2 years old. And then you've got to update it. You say the consumer.
IRS is on our work group, and they're saying that their data is accessible on a real-time basis.
Well, that's great. I knew about that work group, and if I really needed to check this out, I would call you.
I'm just telling you what they said.
But anyway, the point that I want to make about choices among providers is, will the exchanges be value purchasers? Jim Fawcett wrote a book, Courtney, you worked on it, on 5 states. Were they value purchasers for Medicaid? Were they making choices among providers? And the decision that you and Jim came to, it's published in Health Affairs, was, well, not really. John Kingsdale, who is the author and advocate of the Massachusetts Connector Program, and Massachusetts is one of our states. I've been there about 4 times and talked to people there, commissioners and the staff, and when I thought we might have some money, I was trying to hire some people from there, but now I don't know if we're going to get the money. And everybody's going to work for the feds. Everybody in this business is having a hard time getting the staff, not only because they can't pay them and compete in the market, but because they're all a lot of them being sucked up. But anyway, value purchasing is what Massachusetts Connector does, I think. I don't think I know quite enough about it. I don't know, I should say quite. I don't know enough about it. But Enrique Abelson's written really good stuff about this. Is the exchange going to be a yellow pages for insurance companies, or is it going to be a value purchaser, make choices among providers, says Deborah? Well, the question that Deborah also mentioned, as another question that now next year the legislature has to decide here in New York, is what's going to be the structure of these things? In New York, rates are set by the legislature. That is a terrible system. And most states don't do that. Most states don't do that. Maryland, California, there are a lot of variants, but Kingsdale argues, and he has an article in Health Affairs, very good article on exchanges, that you need to have an insulation. Tom and I have talked about this a lot. You've got to insulate the politicians from themselves. It's just like DWI. I'll drive the car when I'm ready, but for now, will you please drive it? So in Massachusetts, how do you deal with conflict of interest even if you have an insulated board? So these governance questions, one of the committees I'm on is about, funded by the Johnson Foundation, setting up a model law for exchanges. And so, can you have a model law? What should the model be? To be driven by whom? And how do you deal not just with insulation, but with naming people who have tenure for a while and don't have skin in the game? The politics of this, and Deborah shows you a lot more than certainly I could ever know about New York, but we have to know that level of stuff about every state. And we can't treat all states the same. I've thought for years that one of the problems of federalism is the sort of Washington reflex of, we know everything and we'll tell the states what to do. Well, some states, Wisconsin, I'll mention, Utah, Massachusetts, California, I think, they did pass the law. Schwarzenegger and Doyle, who were out of office in December, wanted the law passed so they could set up the exchange the way they think it should be before they leave office. Now, what's going to happen when they leave office? And who's going to be appointed? I mean, these questions are so huge, but they're not. And New York has wonderful, smart people, many of them sitting in this room. But you have a lot on your plate. And what else is saying, what Dick Nathan says is, care about this big elephant roaming around out there. It's crucial to the fiscal and economic future of our country as the economy relatively declines in the world. And New York is a very expensive state. And even though you do a lot of smart things, still true. So it is a tall order, and it's a 50-state tall order.
We're just about at the end of our time, but I can allow one more question and one quick, or a couple of very quick answers. Does anybody have anything else?
Yeah.
Yes, sir.
Just a quick question. Richard Bachrach, citizen.
I'm going to hold it for you, Richard.
Right. You mentioned affordability and the future of our economy. There are many thoughtful physicians and others who don't think that the fee-for-service mechanism is compatible with cost control. And I'm just wondering whether in New York State there could be some experiments with something, a list that a doctor has to take care of rather than a fee-for-service mechanism.
I want to go first on that, and this is going to be short Arnold Relman, I read it now that I have retired, I read the New York Review of Books. And he has a book, a lot of articles, that we just have to get rid of that. Fee-for-service medicine and private for-profit health insurance, there's no other answer. Here's an article in the current issue of New York Review of Books that there's no other way to go. Richard, this is at the state conference, used to be my physician. And we went to high school together. I know his views on this. And I think he's absolutely right. It is a real test of whether this law can do enough with a political system as unwieldy as ours. Period.
Deborah, did you
Well, one could spend quite a long time responding to that question. I think the answer is the area where New York controls is Medicaid. Nationally, and then nationally, 80% of Medicaid care is still fee-for-service. So what we need to do is get our fee-for-service payment methods and payment levels rational, and then we need to build away from fee-for-service, because if you bundle a payment, you bundle fee-for-service payments. So if your fee-for-service payments are irrational, your bundling is irrational. So we have to move away from fee-for-service, and then we should not forget the effectiveness of New York's Medicaid managed care program, which at the level of the plan is a capitated payment and has facilitated significantly more data being available and some place to hold accountable. So there's no one answer is my point. We need to move ahead. We need to move away from fee-for-service, but we can't pretend the fee-for-service doesn't exist as we move away from it.
Well, thank you very much, both of you.